discard the ampule after every injection. I haven't found any contraindication. And let Dr. Diwaker start his talk by answering his question, answering this particular question, because he has been one of the inventors of this procedure. Dr. Diwaker, over Dr. Diwaker.
Thank you so much, Dr. Prakash. I thank you all to have this session of office orthopedics. This is the future of orthopedics incorporated in IUA. I thank Dr. Karne, Dr. Shinde, Dr. Shiv Shankar, those who has given support to this sort of platform. And now we shall share the future of the orthopedics. So first now, the side effects of Xylocaine. The question asked. Only 2 years back, the Xylocaine manufacturer have added something which gave sympathetic shock to the patient. And I have reported one every week. And I was worried about it, that what happened. But for last 1 year, the Xylocaine which is coming, it is free of the side effects. I don't know what they had 2 years back. Or the corona made some difference, that with corona, it is unsafe. It gives shock. That I can conclude. So any other question, we'll answer later. So now let us start with the
Yes, sir, you may start.
Microinvasive evolution. I am clear in my voice? Am I clear?
Yeah, sir, your voice is very much clear, and we can also see
your voice is very clear. Please go ahead. Please
Okay.
Clear voice.
Okay. So what microinvasive means first? We have mini-invasive, we do some incision. In micro, we do not damage any of the tissue. So we have some devices, and the device is known as intramuscular needle 24G. You must have seen so many injections, but you have never seen any scar sort of thing with a needle. So I concluded it is a microinvasive, and this is an evolution which has taken 30-40 years in that. So now needle length, what we are using in India is a hypodermic needle, and we think it is an intramuscular needle. No, it is only a hypodermic needle. Intramuscular needle is very, very long. You can see intramuscular needle comes 7 by 8 inches to 1.5 inches. But what we are using it only 5 by 8 or 6 by 8. So, but because Indians are thin, we have less fat. So hypodermic needle being used as intramuscular needle, no problem. But in any case, you have fatty persons, you try to buy intramuscular needle itself. So the thing, just I read few years back in Camp Charlie's, that percutaneous pinning by Kapanji. What he has used, intrafocal means he enters through the fracture site itself. And it acts as a buttress against displacement, and good results in literature. But why it is not so popular? The reason being, it is an invasive procedure. K-bar are thick, they produce a skin scar, and they produce some displacement on the fracture site. This was the technique he has used. He used in manipulation with a syringe and needle, and he manipulated fracture and coaxed rather like a joystick and fixed the K-wire right in that way. So we insert needle in same way as hematoma block. This is intrafocal wire of Kapanji. You can see the process of hematoma block through the fracture site. And I have transformed this with my microinvasive, because K-wire is mini-invasive. Microinvasive because it doesn't produce any scar or any lesion, and even if you pierce the tendon, it doesn't produce any damage. You can insert the needle through the fracture, and a hair induction do not displace with the size of needle. The two reasons. Number one, needle is collapsible and compressible, and it is already very thin. And third thing, is so sharp that it can enter from any point. So trillions of intramuscular injection have been given globally. Skin scars never seen by 24G needle. Impalement of nerve and artery unheard till now. Only venous blood penetration. Sometimes you penetrate a vein and you get a blood inside. So you have to suck it back and see whether it is inside vein or not. Safe to traverse skin, fascia, muscle, physis and epiphysis. This is very important for the orthopedician by which we can traverse physis and epiphysis safely. You can cut a needle at hub like this. Hub means the plastic thing which fits in the syringe. You can cut from the hub and leave this white bead. So it makes a small olive wire. It can be bent to make a no snare staple. That I'll show you later on how it is bent to make a staple. Used as a pad to fix cut or amputated distal phalanx. For distal phalanx amputation, no microsurgery is needed. You simply insert this needle. Available at every corner of the globe, sterilized and unlimited amount. This is the beauty that you can ask in any small place. You get this instrument and the driver, that means the syringe is the driver. You get both freely available all over the world. And sharp enough to pierce thick skin or the nail bed. You can push the needle through the nail bed. It goes easily. Otherwise, if you try to suture nail with a cutting needle, it is very difficult. And sometimes if you try to suture the heel skin, it is very tough to penetrate, but our needle penetrates very well. Intrafocal pinning holds reduction very well, allows motion, no splint, no rest. This is the best thing because it doesn't traverse the joint. The thing is inside shaft. If you use K-wire, it is never inside shaft. It has to traverse at least one joint. So you see this case, the fracture here in two, and the needle inserted like this, and then cut like olive. So it looks very good like mirrors. Previously, I used whole syringes, and the syringes looked very bad. Patient used to say, "Oh, what have you done? Why did you put this needle?" But this looks like some implement or instrumentation. Phalanx fracture are best suitable for needle fixation. You can see here the case and after fixation. Until I read about Kapandi method, I was using same method as a subperiosteal needle fixation. The moment I read about Kapanji, I thought this method looks better, and it is better. Although I can supplement intrafocal needle with the subperiosteal as well. And you see, person, the fracture and needle fixation. And because the needle tend to extrude out with the movement in bed or something like sleeping or bathing, so I cover them either with a thin layer of plaster or elastoplast or anything. Foot also behaves nice to the needle. See this case of a child, massive edema. And then I try to reduce first. In X-ray, it is not very well reduced. Then after reduction, I inserted few more needles. And see, after removal, 50 days, the good union is there. You can see the callus. And the beauty is the patient was walking in the plaster boot. He was advised not to put too much pressure on the toe, but he was walking on the heel. So he was working from the day one. Fracture is very well maintained and very well united without side effect. And what was the cost to me? Only 2 rupees for the needle. Dislocation of epidermis is the best candidate for microinvasive because you are going to traverse the joint and tendon also. So K-wire is inept. You can fix with a subperiosteal needle, 1 or 2 needles, and allow full motion. Remove after 10 days. For dislocation, 10 days is sufficient. This patient, last August, you can see this fracture. And after insertion of needle and a envelope of thin gypsona, hand is free during healing phase. It is totally free, like he can do anything. This is 3 weeks old dislocation came to me, DIP. I have reduced it, put the needle. I have put needle through the joint itself. So the needle acts as a peg and it doesn't allow motion of the phalanx over the joint. And you see, she is moving fairly good. Something has happened. I have to restart.
Yeah, sir, we can't see your PPT now.
No, it just me stop now.
Yes, sir. So by the time you are able to share your PPT
Yes.
with K-wire, yes, we have a Manman or any drilling system by which we can drill across the bone. How do you manage to pierce the cortex with the help of the needle?
No, there is no need to pierce the cortex. You go through the fracture gap itself. There is no need. Simply you have
So
to
are there
enter.
any contraindications to using this technique?
There is no contraindication. It has been used very well in all
What
cases.
Arvind Diwaker needs to say is the syringe acts as a plunger and a driver. Use a 10 ml syringe with a needle and hold the 10 ml syringe in your hand. That will give you a very good control. You can see it under C-arm. You can slightly shift it, bend it, and you can pass the wire. I have used this in a number of cases, and I found it far superior to power-driven or even manually driven mirrors things. You just lock the lower lock to a syringe and gently manipulate and push, it goes beautifully. Needles are really sharp, sterile, always available, and for especially small bones, it is like wonderful and magic. I could understand Dr. Diwakar's problem was he was trying, he had put a whole big slide with so many stills and a video, and when he started playing the video, it froze. So keep going forward, Don't play this video, don't play the video.
Okay.
Just, we will agree that movements are there. Now we can go next.
Yes. The Mukesh case came with the buddy strapping. Some local doctor have given a buddy strapping, as it has been taught to us that you can simply do buddy strapping and it will work. In the strapping, it was totally displaced. I told him that what you want K-wire or you want mini invasive? Then he said he'll come few days later, and he come 5 days later. So then you can see in the strap given by the doctor, still the displacement is there. 5 days later, he gets X-ray done in stepping, and I have shown him it is not replaced. So I did this just before final, inserted one needle, then more needle, covered with the plaster. The plaster is much better cover. A thin layer of gypsona over a simple bandage, it makes a better cover. It saves the needle from the extrusion. And you can see on day 3, the person is working only on single, nobody is strapping. And when I have removed at 6 weeks, I have found that if needle removed for 6 weeks into phalanx, it gives redisplacement. So please do not remove the needle for 6 weeks or preferably even 8 weeks, because the patient is moving, he has no problem. You can see good union and almost you cannot see, and the motion is very well maintained. Now it is without.
By the time you are again able to share the screen, do you ever have had a secondary migration of this needle?
Needles migrated until I have put them a cover. Needles have been migrating.
Can you enumerate more on that thin layer of gypsona that you put around it?
Yes, you simply give a simple bandage and give a thin layer of gypsona around it. Yes, this is the problem. Some video is not playing.
Dr. Diwakar, you have a small issue with your PowerPoint, which is not updated to the latest version. So all videos, every time you are trying to play a video, it is hanging.
I am not going to play. Even if video was not played,
So
it
we are
was not
accepting
working.
that your video functions are good and do not play videos. Just
I am not playing. Even without playing, it was hanging. So now there's no more video now.
Okay.
Now no more videos.
It won't hang.
So it won't hang. For children's 1 to 4 Salta Harris injury, it is unmatched and safe fixation. Because people are maybe happy with the K-wire, but I am not happy. I wanted microinvasion. And the microinvasion beauty is you don't need anything. You need no OT, no anesthesia. You can fix under C-arm or X-ray machine. And that too quickly. So this was the patient. The X-ray he brought was poor. And the quack gave him this sort of bandage, a splint. I took him to the OT. First I insert a needle just to see whether I am in the right place. Then after reduction, I insert the needle fully. You can see the interim reduction and the final reduction. And immediately after plaster ablation, you can see the plaster over the arm. That plaster is recently applied because hematoma block is given. There is no pain and he is allowed to work. He can go to school even. And he comes after a few days, although I do not paste it photograph here. And for collisis fracture, Barton fracture, and especially Smith fracture, this needle is very, very good. For collisis, it may not be good. Why? Because of the dorsal comminution, it doesn't act as good as without comminution. But in Smith, we never have comminution. So it is very well fixed. So this is one collisis fracture you can see here. Needles have been inserted and the plaster applied because needle do not hold. But needle stop redisplacement during the plaster, which will always displace if the plaster gets loose. So here with this plaster and the needle, even if it gets loose, it doesn't displace. This plaster has been opened recently. She has just gone home happily. And the case, collisis fracture, needle put, and the plaster given. And the unending saga continues. Why needle work better than K-wire? Easy availability, readjustment done anytime in OPD whenever needed. Unlike K-wire, you have to go to OT and ask for the anesthesia. But needle can be readjusted in the OPD itself. As I told, it is non-traumatic, almost zero traumatic. No need of operation theater or anesthetist. Never breaks. Many doctors have asked, what happens if needle breaks? It has never broke. Never. Never infects. Full motion allowed. Stiffness is minimal. Easy to remove. Patient can remove even himself. And long record of success. Long record means 40 years. And what I have to say, at IOS or the office orthopedics, we work in reverse. We try to make molehills out of the mountains rather. You treat same thing with the mountain, I can treat with the molehill. Thank you so much for listening. And Dr. Karne for giving me this chance to explain my new technology.
Thank you, Dr. Diwakar, sir. It was indeed a wonderful talk. So another question for you. Are there any references in the literature where this technique has been used by other
references are Kapandi technique is the reference, and I just changed Kapandi technique with this intramuscular needle.
I see, sir. I see. Fine. So what would be an ideal case for the new generation orthopod to start adapting your technique?
Yes, if it is hand or foot fractures, nothing can replace it. In future, nothing will find, you will find better thing than this. Number two, for all intraphyseal fractures, this is the best fixation. Naturally, this alone works only in the hand injuries. In foot, in collisis, in physis, you need a plaster slab. If it is a children's physis, you need plaster slab for 2 weeks or 3 weeks only. But it is used as a sole fixation for the hand fractures, 6 to 8 weeks should be must. In foot fracture, I keep it for only for 4 to 6 weeks. But in hand, I prefer 6 to 8 weeks. 6
So
weeks.
can you again come out with the needle number that you use?
I use
Your
only
favorite?
one needle, that is 24G. No other needle. Neither 23 nor 26. Because if a 26 needle is used, it doesn't give good fixation and length is very small. If you use thicker needle, the fracture may displace. So naturally, you can think that K-wire is much thicker than any needle.
So thank you for the wonderful talk. Dr. Prakash, sir, do you have any question for Dr. Diwakar?
No, I have an input which I want to add to Dr. Diwakar's talk. The thinnest K-wire available with us is 1.2 millimeters, which is as thick as an 18 gauge needle. 1 millimeter K-wires are very pliable and they don't actually work. 24 gauge needle is 0.9 millimeter, but it is heat hardened steel 410, unlike the 316L which is used for the K-wires. So obviously we do not want the injection needles to bend during injecting, and that is why despite being hollow, they are hardened. And needles are manufactured by a special process in which a hollow big rod is stretched and drawn and the diameter is reduced. So the needle will have a much more linear and axial stiffness and penetrative power than an equivalent K-wire of the same diameter. So what Dr. Diwakar has found out is rather revolutionary, that he has converted a mini-invasive thing called a K-wire fixation into a micro-invasive thing called a needle fixation. My only worry in the initial stages was about the tissue reaction to the metal, because a needle is a one-use transient device. It need not necessarily have been biocompatible like 316L, and it could be made out of 410 stainless steel, which might rust. But Dr. Diwakar has tried it in few hundred cases, and the needles come out as polished as they were when they went in. In a similar manner, I have done only half a dozen cases, maximum 10 cases, and I have found no troubles with needles. And we are lucky that 24 gauge needle costs just 1 rupee. It's available sterile, available in every corner shop, in every medical shop, and can be procured at 5 minutes notice for any emergency, and can be used in a large variety of conditions, including reimplantation of digits, soft tissue injuries, patellar fractures. We are writing a whole chapter on the magic of needle, which shall be published eventually, and I shall share the links to all people. So
Dr. Prakash,
Yes.
I have seen rusting of the intramuscular needle. And very interestingly, the needle had been broken and was left inside for 24 years. When I removed it, it was rusted. So it should take at least 10 or 15 years to rust. I removed one needle from the finger.
Okay.
It was actually incorporated into a tendon, lumbrical tendon. And the surgeon who tried to remove it, he opened all corner of the hand and he could not find needle. Then he sent to me with the open hand, open incision. Then I took him to the C-arm and I moved every structure. I found the needle was fitted in the lumbrical tendon and I had taken out, it was rusted.
So technically it
So-
means for
So it was only after 24 years I have seen the needle rust.
so for 6 weeks a needle doesn't rust.
No, I don't think it will rust in within 5 years.
5 years.
Yes.
So that Dr. Abhijit, the question is answer is which was worrying us has been cleared, that hypodermic needles use a temporary fixation devices till the union of fractures, will not rust, and can be repositioned as implants.
And it will never break. It will never break.
Because it is heat hardened, it is stiff. So unlike K-wires which are malleable and breakable, these won't break.
So one final question. K-wire, which is made up of 3161L, is
Yes.
approved for in vivo use.
Yes.
Whether any medico-legal issue may arise for use of needle which has not been approved for in vivo use.
In vivo, we are using intramuscular syringe. It is used for the in vivo use. All the injection after in vivo.
Yeah, so it is used, but then it is removed. It is not placed inside. Here we are keeping inside
No,
for
no, this much,
3
this
weeks.
I will agree with
3
Dr.
weeks.
Abhijit that currently, if any complication happens because of needles remaining in for 3 to 4 weeks, because of this unconventional and unorthodox method, and the patient wants to sue you in the court of the law, you may not have a very strong wicket to stand on. So, to avoid this, we have to take a special consent from the patient that because I do not want to afford anesthesia and theatre, I am subjecting myself to an alternative method of using hypodermic needles, which has been proven safe by the surgeon in his hands, and I am willing to take the risk.
Okay, fine.
Like even for sodium channel blocks, we have special consent, and Dr. Karne, I think, should be having a talk during the next Sunday or Sunday after that in detail about the medical legal aspects in office orthopedics and consent forms and how to take consents and what are different consents. His talk will be a 45-minute to 1 hour talk. We were just discussing. And in that, he will tell that we are now moving towards litigative times where consent is more important than the surgery. And the language of consent is still more important. So we should be able to take proper consents for all sorts of procedures.
So, sir, that's a very important disclaimer that you have highlighted. So, thank you for that valuable input. As we are running short of time, on the behalf of West Zone Indian Orthopedic Association and along with my team, Dr. Ashish Nis, who is the co-moderator, and Dr. Ashok Ghodke, I thank you all for joining today's webinar on office orthopedics and giving your valuable input to make it highly successful. Again, on the behalf of West Zone Indian Orthopedic Association, I thank you everyone and hope to see you next Sunday at the same time, that's 5:30 p.m. onwards. Thank you, Dr. L. Prakash and Dr.
Thank you very much, Dr. Abhijit.
webinar and making it successful.
Thank you very
sir.
much, Dr. Abhijit. And I must thank, very special thanks to Neeraj Bijlani, Ashok Sham, whom we have forgotten to mention, who have been doing all the IT work for this. So my very special thanks to both Neeraj Bijlani and Ashok Sham for making this event a wonderful success. Thank you very much. Thank you.
Thank you, Team Ortho TV. And now you all can stop going live. Thank you.
Remove it. Right click.